Welcome, everyone. Bienvenidos. Thank you for joining us for this virtual UHealth International Medical Series presentation, Innovations in Neurosurgery, featuring distinguished neurosurgeons from UHealth, University of Miami Health System. I'm health journalist Ileana Bravo, and I'll be your moderator for tonight's program. As we get ready to let so many people in from all over the world joining us tonight, we'd like to remind all of you that our experts are ready to take care of your patients in one of 5 Florida facilities. It could be for in-person consultations, for second opinion consultations, or via telemedicine from the comfort of their home. To refer a patient, we invite you to contact UHealth International at 305-243-9100 by email at uhealthinternational@med.miami.edu or by visiting uhealthinternational.com. Tonight, we're privileged to be hearing from 3 experts who will share emerging neurosurgery innovations and how they can be used to help you provide the very best care for your patients. Dr. Alan Levy will present spine and peripheral nerve surgery. Dr. Jacques Morcos will present brain tumors and skull-based surgery. And Dr. Eric Peterson will present vascular endovascular surgery. Now, we'd like for you to be active participants tonight. So during the presentation, we will poll you, the audience, on topics relevant to each discussion. Your responses will be anonymous, but we really encourage you to take part. In addition, throughout the presentation, you have the opportunity to ask our panelists anonymous questions using the Q&A feature at the bottom of your Zoom screen. We've all become Zoom experts now, so take a second to locate the Q&A bubbles there, which is where you will enter your questions, not through chat. And feel free to enter them as you think of them, because we're going to tee them up for the panelists at the end of each of their presentations. So with that in mind, it is my pleasure to introduce our first speaker this evening, Dr. Alan Levy. He is a tenured professor and chairman of neurosurgery at the University of Miami Miller School of Medicine, chief of neurosurgery at Jackson Memorial Hospital, and the Robert M. Buck Distinguished Chair in Neurological Surgery. He has a very busy clinical practice that focuses on complex spinal cord, spine, and peripheral nerve disorders. He's been at the University of Miami for the last 27 years, including completing a PhD in neurosciences. He completed his residency at the University of Toronto, as well as a spine fellowship at the Barrow Neurological Institute in Phoenix. He has served as national director of the AANS Oral Board course for the last 14 years. He is an elected member of 2 of the most prestigious neurosurgical societies, the American Academy of Neurosurgery and the Senior Society of Neurological Surgeons. Tonight, he will present spine and peripheral nerve surgery. Please join me in welcoming Dr. Levy.
Well, thank you, Ileana, for that introduction. Greatly appreciated. And I will start sharing my slides. Hopefully you can see them there, and we'll get started. So my topic today is on new innovations in spine and peripheral nerve surgery. But before I do that, I just wanted to give a sort of a brief introduction of our faculty. Right today, you'll hear from 3, or you'll hear from 2 stellar colleagues of mine, Dr. Morcos and Dr. Peterson. But our faculty consists of about 21 other neurosurgeons who cover the entire gamut of neurosurgical problems. You can see that from this picture that they are trained in multiple other areas of the United States. And they cover spine, cranial, neurotrauma, pediatrics, functional, neurotrauma, and as Ileana said, we provide services at a number of different hospitals and clinic locations listed here. For the most part in Dade County, but through telehealth, our reach is certainly global. And not only do we have phenomenal neurosurgeons, we have terrific what we call physician extenders, PAs, and APRNs who can help with the process of getting into the neurosurgical treatment program. And just as a feel for the gamut of our reach. This is our annual international surgeries that really cover worldwide patients. And so it's a message to say that we would be very comfortable taking care of either you, your patients, your family, should you refer them to the Department of Neurosurgery at the University of Miami. Not only are we a strong clinical program, but we're incredibly strong in research and innovation, and that's reflected by our NIH ranking and our centers of excellence, including the Miami Project to Cure Paralysis and the Brain Tumor Initiative. We have a fantastic training program. People come from around the US, Canada, and the world to get training in our centers. And we typically train 21 residents, 10 fellows, and have observers that come from around the world to see neurosurgery performed in our center. We opened a new spine and brain institute at the UHealth Tower last year officially, and it consists of 6 operating rooms, 14 clinics, and 3 physician offices. And as you'll hear from my colleagues, we're very multidisciplinary, working with ENT, orthopedics, neurology, as required. So with that introduction, I'm going to get into the focus of the talk, which are innovations in spine and peripheral nerve surgery. We're going to talk about spine first of all, but you know, even with innovation, at the end of the day, our goal is to make happy patients, whether we do it the old way or the new way. That's our absolute focus. 2 spine technologies that I wanted to talk about that are at the University of Miami include the Mazor Robot, and you can see my colleague Dr. Wang here using this robotic arm to assist with spine surgery. Off to the side, you can see just a part of the O arm, which is one of the many surgical navigation tools that we use so that we can correlate intraoperative anatomy with the patient's pathology. And you can see in this image here, the O arm off to the side, and again, the robot helping with the surgery. So the other innovations in spine that we're very proud of is something called enhanced recovery after surgery. And what that means is it's developing an algorithm that's been used in many different surgical disciplines, where we try to get the patient in and out of the hospital as quickly as possible with the smallest potential incisions. And that leads to reduced costs, happier patients, and equally as good outcomes. And how do we do that? It really requires a team approach that's patient focused. And I'm going to talk about some of the innovations on this next slide that helps with enhanced recovery, which includes perioperative nutrition, using long-acting local anesthetics, and using techniques to insert instrumentation that are through smaller incisions. Obviously, the goal of this is, again, to enhance outcome, reduce narcotic intake postoperatively, and make patients more comfortable with the concept of undergoing surgery. Again, this is sort of a picture showing some of the things that we do in spine surgery to make things minimally invasive. And a lot of it is focusing on innovations in perioperative pain management. So just to show you a typical example, when we're doing a lumbar fusion, when we compared it to the pre-ERAS area, that there's a significant reduction in the length of stay, in the use of narcotics, and that's reflected on these two slides, or reflected on that slide here, showing less medications with the ERAS protocol. Another spinal disorder that we take care of is that of spinal deformity. And that really is a term to mean when the spine is not aligned straight. And that could be scoliosis. It can be something we call sagittal deformity. But essentially, this patient's x-rays will show that they're pitched forward, for example. And so the goals of spine surgery have always been to compress nerves, to fuse the spine when appropriate, but also to preserve or restore alignment when necessary. And as you know, aging is reflected with these skeletons here. As we get older, we tend to be more crooked and pushed forward. And in most people, it needs nothing specific except for good exercise. But in others, when it happens to a great degree, they can help. They need help with realignment, so to speak. And it matters because it can cause pain, dysfunction, disability. I think the best way to demonstrate that is an example, and this lady is actually, I think, was from Dominican Republic. She's 80 years old. She has some comorbidities, but is generally healthy. And you can see that when she stands, she's very pitched forward. And this is despite compensation that she's trying for her to try to stand straight. She has back and leg pain. She's incredibly limited in her ability to ambulate. She can only walk about 20 feet. And when you ask her what's wrong, she says, I just can't stand straight. So this is what her MRI and her CT scan looks like. We can measure the abnormal angles. The details are not important. And then by doing surgery, we can correct her alignment so that she can stand straight and walk further. And that is shown here in these post-operative films. And when you look at her pain diagram, despite all that heavy metal being put in, she really has no pain at her 3-month follow-up. And the last thing I was going to talk about is innovations in peripheral nerve. Peripheral nerve are those large nerves that come from the spinal cord and supply muscles in the arms and legs and can be damaged from a number of different causes, including trauma. This is an example of a traumatized nerve after someone put their leg through a glass door. We have tremendous collaborations with our radiologists, our neurologists, and we really rely on great imaging of the peripheral nervous system to make decisions. And we've had a number of publications in those areas. We also take care of tumors in the peripheral nervous system. And these are examples of some very small tumors, but occasionally we'll see massive tumors attached to the leg or arm that need removal. And these are typically schwannomas or neurofibromas. Occasionally we will see and take care of malignant peripheral nerve tumors. And again, we've published a lot in that area. The last two things I want to talk about is innovations in peripheral nerve repair. This is something that I've been working on for almost 30 years, but the ability to essentially create artificial nerves. In medicine and surgery, we've been successful in making artificial urinary bladders, artificial tracheas, and what we like to do is to do and make artificial nerves. And we do this by taking a biopsy of the peripheral nerves and growing them in the laboratory and get them expanded. So this is the biopsy. These are obtaining the cells from that biopsy and then expanding them in culture so that we could retransplant them back into the patient with a nerve injury. And since it's their own cells, you don't have to worry about immune suppression, etc. Schwann cells are what we are growing. They're not stem cells, but Schwann cells, and they have a number of important features that engender peripheral nerve regeneration. This is our GMP clinical facility that allows us to grow these human cells and bring them back into the patient. And it's particularly important in nerves that have large gaps in the nervous system where you have insufficient donor nerve to repair these nerves. This is an example of a young lady who had the back of her leg cut up by a motorboat propeller. She had an 8-centimeter gap in her sciatic nerve. We took biopsies of the damaged nerve as well as her sural nerve, grew them in culture, and 3 to 4 weeks later took those Schwann cells and retransplant them back into her nerve repair site. And this is her at 18 months post-surgery, showing that she could move her foot after the regeneration of those axons towards her muscle. And the future, I think, is bright in this area, and we're very involved in creating channels to put these nerves back into. And the final thing I was going to talk about is something called nerve transfers, which we also do for example, brachial plexus injuries, where we'll take a part of a working nerve and sew it back in to a nerve that's damaged. That's what a nerve transfer is. This is where we're using parts of the median and ulnar nerve to reinnervate the musculocutaneous nerve, which is the nerve that controls biceps function. And this is an example in a patient who had this nerve injured some 6 to 9 months before, and you can see him flexing his biceps after those nerves were regenerated. And so I believe that is my last slide. Other than to say we are very involved in education and peripheral nerve cadaver workshops that we held right before the pandemic. And that's all I have to say. So again, that's a whirlwind of information. I hope I didn't go too quickly. I wanted to leave enough time for my colleagues. And thank you for your attention.
Just right, Dr. Levy. And you will be back to moderate all the questions and answers. So first, let's jump into our first poll question of the evening. Let's see what our audience, how they're listening. The newest innovations in spine and peripheral nerve surgery at UHealth include all of these except A, robotics, B, stem cells, C, nerve transfers, D, ERAS program, and E, intra-op navigation. Which one on this list should not be there? And while we're waiting for everyone to give us their answers, and Dr. Levy, you'll tell us how the audience did, I remind you all that you have a very unique opportunity tonight to ask questions of our worldwide experts. And you do it with the Q&A feature at the bottom of your Zoom screen. We will look at the questions, we will prepare them, and Dr. Levy's going to walk us through all of that question and answer session. So please take part in presenting us with some questions. Okay, let's see how we did. What are the results? What do you think, Dr. Levy? You're muted. Unmute.
Yeah, let me unmute. First of all, I want to say this is a very difficult question, and we went through it very quickly. The right answer is B. It's stem cells. We showed you briefly the O-arm, which is an intraoperative navigation device. So that is a new innovation. And when we were talking about cellular transplantation, we were actually talking about Schwann cells. It sounds very similar to stem cells. Schwann cells are from the peripheral nerve, and stem cells are usually harvested from the blood or the iliac crest. So I know it's 6:30 here or late, and it was a tough question. I apologize, but I congratulate the 28% who got it right.
Perfect, Dr. Levy. All right, well, we are now going to move on to our next speaker, Dr. Jacques Morcos. So you can start sharing your screen. And he is a professor and co-chairman in the Department of Neurosurgery at the University of Miami with a joint appointment in the Department of Otolaryngology. He's director of Cerebrovascular and skull-based surgery at the University of Miami Hospital and Jackson Memorial Hospital, division chief of cranial neurosurgery at Jackson Memorial Hospital, and director of the skull-based and Cerebrovascular Fellowship Program. His range of clinical and research expertise includes all skull base and complex brain tumors, endoscopic skull base surgery, radiosurgery, and all aspects of cerebrovascular surgery, including AVMS, cavernomas, bypass surgery for complex aneurysms, moya, and ischemic disease. Dr. Morcos is very active and organized in academic neurosurgery nationally and internationally. He currently serves the following organizations: Vice President of the American Association of Neurological Surgeons, AANS, Chair, Constitution and Bylaws Committee of the World Federation of Neurosurgical Societies, WFNS, Scientific Committee member of the American Academy of Neurological Surgeons, and elected member of the World Academy of Neurological Surgeons. He serves on several editorial boards, including Journal of Neurosurgery, World Neurosurgery, Journal of Neurological Surgery, Part B Skull Base, and others, and has garnered numerous awards and distinctions. His academic and scholarly activities as of May 2021 include 702 invited national and international presentations, 194 presentations at practical courses, symposia, 150 peer-reviewed chapters, other publications, 113 abstracts, posters, and 84 visiting professorships, guest lectureships. He has trained 25 cerebrovascular skull base fellows to date. Whew, Dr. Morcos, I thank God for Zoom, I guess. Please join me in welcoming him tonight.
Iliana, the first, can you hear me?
Yes.
The first award of the evening goes to you for putting up with all the stuff that's on our CVs, but thank you very much for all this. Again, welcome everybody. Thank you for joining us on at least Miami time, evening time. I will talk to you about mostly the skull base program. Really, in 15 minutes, I cannot pay enough justice for the huge brain tumor program that many of my colleagues lead and participate in. So I will talk about skull base program here at University of Miami. You know where we are. This is a beautiful Miami, and the center where we are in, of course, we are, as you heard from Dr. Levy, a high volume tertiary referral center with a great referral base and firmly committed to clinical research and educational missions. Let's talk about the people in the skull base program. You've heard about me, enough of me. I'd like to also remind you that open vascular and skull base really are in a symbiotic relationship. Eric Peterson, my colleague, will talk about both the endovascular and the open vascular to follow me. But I want you to visualize a little bit the schema. I'm showing you how everything interrelates together, and it is very important to be a good skull-based surgeon to also be a good microvascular surgeon. At least that's my belief and my bias, because of all those things that are very obvious to you, how CV helps skull base and how skull base helps CV. If you are well trained in both, you can take a brainstem cavernoma through possibly a skull base approach, like I did on such a case. You can handle complex aneurysms. You can handle carotid arteries in the midst of complex skull base tumors. You know how to exenterate the cavernous sinus and things of that nature. So what is our program? We have a fantastic cerebrovascular program, and Eric will talk about it. There are 3 of us who do this open, and I don't do any endovascular work. We have 2 very talented neurosurgeons doing the endovascular work, Dr. Peterson and Stark, and 1 endovascular neurologist, 8-stroke neurologist. Here is Eric, here is Bobby. And skull-based program is huge. And just read the number of people we have in each sub-discipline of the skull-based program. And I'm not gonna read them out to you. You can see them, you can see the numbers. But what I'd like to do is really flash pictures and mention my 2 active skull-based partners, Michael Ivan, who's now associate professor. Mike is fantastic. He does skull base, he does neuro-oncology, does epilepsy surgery. And Carolina Benjamin, who joined us almost 2 years ago from NYU, also does skull base and brain tumor surgery, as well as general neurosurgery. And we have a fantastic department of ENT one of the, like us, one of the busiest in the country. These are their huge numbers in ENT. And the reason I mention ENT is, of course, they're integral part of what a skull-based neurosurgeon and skull-based program has. And just flashing the pictures, the photos of the people in head and neck surgery, neurootology, rhinology, um, um, which makes up also the endoscopic skull-based program that Troy Cassiano and I started now 16 years ago for minimally invasive skull-based work. We are next to, and it's part of the University of Miami, the world-famous Bascom Palmer Eye Hospital that's been voted, I believe, more than 20 times in a row now, #1 in the US in ophthalmology. And of course, we are the beneficiary of that alliance, and we work closely with neuro-ophthalmology, oculoplastic surgery for these skull-based cases. We work with fantastic neuroendocrinologists who specialize particularly in pituitary tumors. Of course, and all these photos I'm showing you, we actually work with each one of those people. This is not just taking pictures from their websites. We actively work with them. Of course, we're very proud to be one of the few centers voted, chosen to be a team honor roll by the North American Skull-Based Society in skull-based, and for good reason from what you can see. We love teaching. I started about 12 years ago what I call MOBS, every Tuesday evening, multidisciplinary conference of the base of the skull. All of those people you've seen, or most of them, get around the table and we discuss complicated cases. This is the first year. They were celebrating the first year of the program in 2011. And it's grown to be a tremendous asset that I don't think is done anywhere else that I'm aware of to that extent and to that degree. 2 hours every week, getting all these brains around the table to discuss complex cases. Education, we have Mike Ivan and myself have started 2 separate webinars. You are welcome to join us if you're not aware of them. This is what's upcoming, for example. Once a month, you can see the speakers we invite on Zoom. This is the Miami Global Brain Tumor Symposium, the first Wednesday of every month that Mike Ivan puts together. You can go and visit this link to see what else we offer education-wise in the skull-based and brain tumor program. And not too long ago, we opened this fantastic cadaveric lab, the Keynes Lab, to teach. We have 13 stations. And of course, COVID put a damper on things a little bit, but of course, the minute travel opens up, you bet that we're going to be doing very regular courses in this lab. You can see some of the pictures here. Let me take you through some of the clinical and then some of the research program. Of course, skull base and open cerebrovascular. You can see some of the things that we all do on a daily or weekly basis in the program between all of us that I've mentioned, the various people that make up the program. These tumors that you're looking at are a weekly occurrence: acoustic neuromas, cavernous sinus tumors, petrosal approach for petroclival meningioma, perhaps not weekly, but certainly frequently, Kawase drilling, and of course, open vascular. I have a specific interest in moya moya and bypass surgery, and we've developed a technique called I call it the 1D2R, one donor, two recipient. We do a significant amount of open clipping of aneurysms and AVMs, and minimally invasive. I don't like that term, but I'm going to put it in the title because many people quote it. It really should be called minimal access surgery, not minimal invasive surgery. What is it? It includes endonasal endoscopic approach to the entire skull base. This is a nice picture from Roten on the right. Here we are, myself and, for example, Roy Cassiano, working on a case. There are many approaches we use to the skull base. I'm not going to enumerate them, but you can see their initials here. The purple one is the endonasal transsphenoidal and extended endonasal, and the other ones are the classical transcranial approaches. For example, when I compared my experience with microscopic pituitary surgery and endoscopic, because I moved to endoscopy 14 years ago, and it is indeed true that we do a better job with endonasal. The blue columns is rate of complete resection with endonasal in my practice versus my own practice when I used to do microscopic. That's the orange bars. You can see tumor control rates better with endonasal for pituitary tumors compared to microscopic, at least in my hands. Craniopharyngiomas that we used to do transcranial, we generally do endonasal, such as this case. You can see this case here, pre-op. You can see it post-op, gross total resection. Orbital surgery. Orbital surgery, of course, is part of skull-based surgery, particularly when we're working with talented people like the Bascom Palmer folks. And the neurosurgeon needs to understand orbital anatomy. There are many ways to get to the orbit, and we have modified many of those techniques. Again, there's no real time to go in great detail. But for example, an orbital apex schwannoma that in the past I would take transcranially, now we go endonasally because transorbital, because it is medial to the optic nerve. That is, and these patients go home the same day. Of course, the lesion has to be medial to the optic nerve. If it's lateral, you should not do it endonasally. Here is a view with the endoscope. We're about to open the periorbita, and it is some of the simplest surgery because you have a 30-degree angled view. And this tumor, you can see it. It comes out in no time, almost one piece. And as I said, there is no CSF leak issues here, and the patient will go home the same day. Of course, not all orbital lesions are small like this. You can see this large schwannoma. And of course, working with oculoplastic surgeons and myself or my colleague neurosurgeons who do the skull base, these tumors can be resected completely through a cranio-orbital approach, so-called the Hakuba Dolink transcavernous dissection. And here it is post-op gross total resection. We still do a large amount of traditional open skull-based surgery. Sometimes staying with the old and tried and true is sometimes better than doing something simply because it's new. So the key is to know when to stay with the old and when to use the new and the innovation. So a petroclival meningioma like this, I still believe should be done through a petrosal approach, not through an endonasal approach. That's what I did on this particular patient with a lumbar drain, a retrolab pre-sigmoid approach. Here is the view, working with my colleague neuropathologists to help me with the temporal bone exposure. And here is a gross total resection at the end of it. No self-retaining retractors needed. The patient had, as you can see in the bottom right, a 6-nerve palsy. Temporary, it disappeared within weeks post-op. She completely recovered, and this patient has not recurred in many years now. You need to be very, very well versed in the cavernous sinus approaches, the Hakuba, the Kawase, the Dolink approach. It is fiction that cavernous sinus cannot be approached. It is, of course, it's a myth. You have to just know what pathology you can approach in the cavernous sinus. And this is, of course, a huge subject. I cannot get into the details of it today. I will skip, I already said enough about the combination of open vascular and skull base. This was going to show you a previously coiled basilar tip aneurysm that kept recanalizing that we did through a craniotomy and a transcavernous approach. It's a perfect indication to marry skull base and open vascular. Acoustic neuroma program is very active, very thriving. We do microsurgery, radiosurgery with gamma knife and hyperarc. We do NF2. We have a wonderful NF2 program. Auditory brainstem implant. We actually were the first in Florida to implant an ABI in an NF2 patient 2.5 years ago. And actually, thanks to a wonderful colleague from neurootology, Christine Din, she actually is spearheading a basic science research, which I will show you a snippet of after the few case examples. Acoustic neuromas, examples here. We do every approach you can think of: translab, retrosig, middle fossa. And this is a pre-op example of a case that grew after previous surgery done elsewhere. There is post-op with a good facial nerve function, gross total resection. Another big case. This is post-op, 2 years, no recurrence after surgery, and a good facial nerve function, retrosigmoid. Another example. Another large example, we did translab approach. Another example, we did retrosigmoid approach as well. Again, these are team surgeries with neurootologists. We've innovated using the endoscope intracranially as part of the craniotomy to look into the fundus of the IAC. The research program, I'll mention briefly, and to recognize Christine Din, who you can see standing perhaps in the middle of that group there. She's a wonderful neurootologist who is doing fantastic basic science work on acoustic neuromas, and we have a lovely tissue bank, and she is helping with the ABI program, of course, and some of the publications. This is a publication of my cases, 420 acoustic neuroma surgeries. This publication is submitted, and it actually shows we do very well with facial nerve preservation. You can see that it is 81% at 1 year, grade 1 or 2 House-Brackman, which is actually among the best published out there, with excellent follow-up. The correlates of good facial nerve outcome. Who does better? Of course, the smaller tumors. If you can stimulate the nerve at 0.05 milliampere at the end, if they have not had previous radiation therapy or a previous resection. And as I said, if the tumor, of course, is smaller and has a small extension in the CP angle. Future directions of skull base, very exciting. Clinical trials, targeted therapies, improved molecular prognostication for chordomas, meningiomas, many others, centralized clinical outcome databases, centralized tissue banks, and improved imaging, DTI, tractography, incorporation of advanced neuroimaging. I'd love to have usable neurography to see where the facial nerve is. It's not very good yet to use intraoperatively, but hopefully we will get there soon. And many other, perhaps robotics will take over skull base, but perhaps many years from now. We have very active fellowship program. These are the fellows I have trained over the years, very proud of each one of them. And I thank you for your attention. Feel free to contact me at any time if you are interested in our program. Thank you. I stop sharing. Thank you.
Thank you, Dr. Morcos. Thank you for putting up the contact information so that they can go directly and tune into you. Now let's go right to our second poll question, which should be on your screen momentarily. And there it is. And predictors of poor facial nerve function following acoustic neuroma surgery at the University of Miami include all of the following except, so pay attention to the except, threshold of stimulation at the brainstem of 0.5 MA, previous surgery, previous radiation treatment, small intracanalicular tumor, or the patient has NF2 syndrome. Let's wait a few seconds and see how they did, Dr. Morcos. See how your colleagues from all over the world tuning in are doing for these trick questions that you're all teeing up for them. And I remind you all, I see that there is more activity on the Q&A section. So please take this unique opportunity to reach out to your colleagues here at the University of Miami UHealth and enter your questions, because we'll have a very active Q&A session. All right, I think they've had enough time, hopefully, to see. How'd they do?
Well, 33% got it right. It's D. Of course, the smaller the tumor, the better the facial nerve outcome. If patients have been previously radiated, have had previous surgery, The trick one I gave you, and I apologize, I enjoy writing trick questions. If it had said 0.05 milliampere threshold of stimulation, that would have been a correct answer, but 0.5, that's too high. That patient is waking up with a weak face. And of course, NF2 patients are much harder to deal with, but kudos to the 33% who got it right. Thank you, Ileana.
Thank you, Dr. Morcos. Excellent. And now let's introduce our final speaker of the evening, Dr. Eric Peterson, who will be sharing his screen. There it is. He's an associate professor of clinical neurological surgery at the University of Miami Miller School of Medicine, director of endovascular neurosurgery at University of Miami Hospital and Jackson Memorial Hospital. He went to medical school at the University of Michigan, then did his neurosurgery training at the University of Washington before doing his endovascular training at Miami. He then joined the faculty of University of Miami and is now the chief of endovascular neurosurgery and fellowship director at UM. He is a pioneer of the radial approach for neurointervention. Please join me in welcoming Dr. Peterson. Take it away.
You're muted, Eric.
Dr. Peterson, unmute yourself, and we see your slides. There you are. There you are.
Yeah,
Welcome.
sorry about that, guys. All right. Thanks, you guys, so much. I'm going to try to go fast here. I know we're over time already. I'm one of the endovascular surgeons here. I do open and endovascular, predominantly endovascular. And I'm going to show a bunch of different scenarios where we kind of used a whole bunch of different people in our department to kind of get some really complicated stuff done. And it's just a showcase of how there's really not just one tool that works. The old paradigm when I was training was this big fight about endo versus open vascular and what the role of each was. And I think that fight is settled. That there's no question that you can't get away without having both at your center. And I've seen problems in both directions where the place doesn't have good endovascular training and expertise, and also other places that have only endovascular, no open, and patients really don't do well in those types of scenarios. You really need both, because it doesn't matter if you're at a big tertiary center. The stuff that walks in off the street can be extremely complicated, as you'll see here today. These are some basic cases that happened to us at our center that just came in through the emergency room. These are not no one in the world can treat them type things. They get sent to us. This is just what walks in off the street. Ruptured aneurysm, subarachnoid hemorrhage, has this on the right and this on the left. So no way to know where the bleeding came from. The bleeding pattern in the CT scan was diffuse. There was no obvious way to pinpoint it to the ACOM that you see here, or to this large supraclinoid on the right. The standard, the standard teaching there is you pick the larger or more irregular lesion, but you've got an irregular ACOM and a large aneurysm. So we weren't sure. Excuse me, one second. So we decided to treat both. So what we ended up doing is doing a balloon assist coiling for both of these. And we ended up having, I'm sorry, you guys have to mute me. Give me 1 second here. So we treated both of these with the balloon assist coiling. First on the right, the ICA, and on the left, the ACOM. Had a good result with both. Patient had a small headache afterwards and was found to have this small occipital ICH. And then the day after this, developed a hemiparesis and became plegic. We did an angiogram and we found that her carotid had shut down, presumably from the large coil mass near that carotid. She was filling across from the ACOM, but there clearly wasn't enough flow there to that right hemisphere, which was causing the deficit. And now we have increased flow across the ACOM, and we've got a new recurrence here on the ACOM, and it's compacted the coils. We do some advanced imaging, and it shows that the entire hemisphere is down. So the only way to manage this is to increase the flow to that hemisphere with a bypass graft. There's no endovascular option for this. So we proceed with dissecting out the superficial temporal artery in the skin. And then you graft that directly into the brain vessels. them some extra augmentation of flow from the skin vessels to make up for that carotid. Here's how it looks at the end. And then her flow reduction was improved. We had that ACOM recurrence we had to fix. So we had to treat this with an advanced endovascular technique with a stent. We have these very small stents now that we can navigate into position through even very small catheters. This is us tracking the stent into position. Here's the deployment of the stent. As you can see here, you unsheath the stent right there. And then once it's over the neck of the aneurysm, you're able to fill in the rest of that residual with coils, and you get all the way down to the base here, and you just have the ACOM that's open. This whole residual has been closed off. There's a different type of skills, another complex brain aneurysm. We tried to repair this endovascularly. We couldn't keep the coil sitting in the dome. It's a rupture, so we couldn't use a stent. The old way of doing this would be to take off a window of bone and pull on the brain to expose this area. But with advanced Embolic techniques that, like Dr. Morcos showed, you can remove a small piece of bone, and you actually improve your surgical trajectory and avoid pulling on the brain. So a piece on the orbit allows you to look from a lower trajectory, looking up rather than pulling the brain up. You just look from lower, and you're able to get a much smoother trajectory into the aneurysm location. And then you're able to clip the aneurysm. This is the contralateral. This is the ACOM right here. So you want to get your clip blade just to sit just perfectly on that. This is ipsilateral A2. This is inspecting things afterward. That's contralateral. That's ACOM. You can see the clip is just perfectly on it. Hypothalamic perforators posteriorly are all preserved. Close-up angiogram looks great. This is a different case. This was Dr. Morcos' case, if I recall. MRI showed extensive flow voids in addition to the large size of this tumor. So there's a concern that this would have a lot of blood supply that would be difficult to get to at surgery. So he referred it for a catheter angiogram to assess that. Angiogram showed, as you can see, a massive artery feeding the deep portion of the tumor off the anterior carotid artery. This is a deep feeder, right? Very, very vascular tumor. When you're doing your surgical approach from here, you're going to be getting this bleeding feeder at the very end. So you're going to be fighting this pipe the whole way in. So if there's any way we can close off this deep feeder, it makes the surgery significantly easier. Intercoroidal arteries are in general high risk for embolization because they have a lot of brainstem perforators off them. So you have to be well past those choroidal points here and past where the brainstem perforators come off, and try to get your wire and catheter way, way out past and not let any reflux come back at all. You don't have much of a reflux margin for error there. So if you get far enough past and you're careful with your embolization with glue or onyx, you can just do just a tiny little bit, just enough, and not wait for there to be any reflux. So you see, we fill that huge pipe up. Perforators are way back here. I don't let any reflux happen. As soon as I see the slightest bit right there, you stop, right? So in general, you're in a risky artery, but if you're heparinized and you're careful, you can fill up this massive pipe with the onyx, and you just watch right there. And as soon as you see the slightest bit reflux like that, boom, you stop. And so we got a really good result. You can see the whole tumor is shut down. That choroidal vessel is filled all the way to here, giving out the perforators. So you preserve all this, no injury, but the rest of the tumor is shut down. And of course, it's easy work for Dr. Morcos. This is a different thing that our center does a ton of. This is retinoblastoma, not a traditional neurosurgical procedure, but these patients have a terrible outcome. Oftentimes, I think they're eye enucleated because the chemotherapy is too toxic to be high enough in concentration. But it turns out that if you can get a tiny little catheter into that little ophthalmic artery, you can infuse very, very high concentration of chemotherapy directly into the tumor, and their systemic dose is quite low. So the tough part is just getting the catheter into that little artery, which actually isn't that hard. It often just flips right in. You pull back your wire, and if you can see right there, boom, see that little flip? Now you're inside the artery. And when you do an injection, you'll be able to see the entire blush of the ophthalmic artery and all the little arteries into it. You infuse chemotherapy directly into this, and you try to dramatically decrease rates and enucleation rates and cure rates with this technique with globe-sparing strategies. Another thing that our centers, as Dr. Levy and Morcos mentioned briefly, is that we've been a pioneer of another way of trying to take some more invasiveness off the table for our patients. I remember when I was training to how to do open neurosurgery and I learned endovascular, I thought, man, this is the way of the future. I can't believe I'm able to reconstruct everything through this tiny nick in the groin. It really did seem like a way that was going to become more and more popular over time. But even this one has its own invasiveness and its own complications. This is a big artery you have to poke with a needle. It's deep in the pelvis, and you can lose your entire blood volume like this. And the cardiologists have pioneered a way of doing these entire cases through a different artery, but no one really has done it in neuro. Our center started to try to do that and have become one of the thought leaders around the world for doing all of these neurovascular procedures, not just endovascularly, but not even femorally, through the radial artery in the wrist, through a tiny little puncture in the wrist. You can use this conduit rather than this one. It turns out it's significantly safer. It's just a little more challenging to do, but with enough training and expertise, along with some hopefully improved technology, you're able to actually get a lot of these cases done this way. And was part of a joint venture where they developed a catheter system that allowed people to actually access the brain vessels, just like the cardiologists do, through the radial artery in the wrist, rather than using the femoral artery in the leg. So we now do the vast majority of our procedures this way, through the wrist artery and the radial artery in the wrist, not through the femoral artery in the leg. And you can see from this approach, you're still able to get a catheter system all the way up to the distal carotid and do the vast majority of procedures this way. This is no longer something that only the cardiologist can do. We do about 90% of our procedures this way. Here's some cases like that, just so that it can be done. This is a pipeline case. Pretty tough bend here from the radial approach, but the catheter has really no problem tracking up all the way around. As you can see here, sailing right up the carotid left side, which is traditionally the hardest approach for radial. Now really no problem for these new catheter systems. Again, you can see the same thing here. Catheter is tracking all the way up from the radial approach, just like a femoral case, except we've taken all that axis morbidity off, goes all the way up to the brain. Very nice. And you can use some complicated cases like this. This is where you get the catheter even from the radial approach, no different from the femoral. You're able to do pipeline flow diversion, thrombectomy. This is a really tough angle here, left-sided case for a middle meningeal embo. You're able to track that catheter all the way up in position. And this is a very challenging anatomy that we're able to navigate also with the wrist catheter. I'll stop there.
All right, Dr. Lev, thank you so much, Dr. Peterson. Let's go to the final poll question of the evening before we get to our question and answer. And that is, what is the role of open versus endovascular techniques for brain diseases? And let's put that up on the screen. A, open is better as it is more established. B, endovascular is better as it is less invasive. Or C, both techniques need to be offered at an institution, as these diseases can be very complex to manage with a single modality. So let's see how our audience does on this one. And Dr. Peterson, you can comment as to whether they did well. Before we get this ready for me to hand the microphone over to Dr. Levy, who is going to do our question and answer session. I know several questions have been brought in, so let's see how they did. I'm assuming they're right, Dr. Peterson.
Yep, looks great.
All right, thank you so much. All right, Dr. Levy, it's all yours, and I know that you have a few questions, so take it away.
Well, thank you. And again, Ileana, thanks for moderating. You did a terrific job as always. I'm going to see what we have going on the Q&A that's recent. I think we've answered all of the pending questions. So maybe what I'll do first is ask Dr. Morcos as what he sees in terms of robotics. You had mentioned a little bit as that being a possibility in your field. Where do you think it's going to be first implemented? It has a history of over 30 years in neurosurgery, but hasn't quite broken the barrier yet in cranial.
No, has not. You know, the closest we are at it is, as you know, our colleague in head and neck surgery used the robot to remove tonsillar cancer. The problem is, I think perhaps companies don't see too much financial incentive to develop it for intracranial. For example, bypass surgery, there used to be like a stapler device to put the bypass together, but there isn't enough volume to warrant what they would do for coronary bypass. We would all love micro-manipulating arms at the depth of the skull base to suture, to even resect tumor, to eliminate human tremor of the surgeon, and you know, in peeling things off the nerve. It's a matter of applying the technology, and it's not there. And it certainly won't be there in my remaining career, and I hope it will come as our current residents near their mid-career. We'll see.
Awesome. Dr. Peterson, you clearly have been an innovator from getting us from femoral artery to radial artery, and has shown it's safe, effective, and your group has published a number of different articles in that arena. What's next? Is it temporal artery? Is it hair follicle artery? I mean, you guys are getting smaller and smaller. I know you're already thinking of what the next innovation will be. Maybe you can share it with us without losing too much IP.
Yeah, I think rather than any specific idea, I just think it's important that physicians are thought leaders here. I mean, for the most part, physicians have abdicated that responsibility of creating new things and new technology to other people, and they just want to focus on taking care of patients. And that's certainly quite reasonable. But those people that do end up doing it are nowhere near as qualified. They're not at the bedside. They don't see the patients. They don't see the real pain points and the problems. And there's a lot of opportunity that's left out there that we are dealing with all the time that drives us crazy and hurts our patients. And no one really steps up and tries to make something to take care of it. And we're the best position there. So everyone has a lot of great ideas. And I just encourage everybody to take ownership of it, because you can really change a lot that way.
Hey, Alan, can I ask Eric a question? Eric, I remember many years ago, there was this excitement about magnetic navigation, like, I don't know, carrying the tip of a catheter through a magnet. But is this totally obsolete? It's never going to be a good idea anymore because of the technology of the micro catheters now, number one. Number two, will liquid embolic ever come back for aneurysm treatment, or just you think that concept is not viable anymore?
Yeah, those are great questions. Liquid embolic is a tough one, right? I mean, you're squirting a liquid into essentially a garden hose of blood flow that if any particle goes out, you have a stroke. So I think it's just a really tough problem to solve there. And with flow diversion and intrasaccular devices, as good as they are, it's tough to imagine why you can get to take that kind of a risk. So I don't think there's much of a place for liquid embolics for aneurysms going forward. Your first question was about what I forgot. Oh, the magnetic thing. Yeah. So that's really exciting because people would be able to avoid radiation completely. It's a challenging technological problem to solve, and people have been chasing that a different way with either shielding themselves completely with these specialty bottle suits, so we don't have to wear any lead, or doing essentially remote robotic endovascular, where the patient maybe gets some radiation, but frankly, the patient's dose is relatively low. It's really the physicians that are there day in and day out that really get the high dose, and doing the remote system, even if you're 20 feet away behind a shield, solve that problem. But I don't think it's dead. It's taken longer to develop than I think people anticipated.
Well,
Alan, can I ask you a question?
Absolutely.
So stem cell, are our residents going to use them efficiently, effectively in their career? What has been the biggest hurdle, and how do we stop all these charlatans out there injecting stem cells into joints and stuff? You know what I'm saying? This is an epidemic, no?
Yeah, that's a 1 hour response, because there are very many type of stem cells. There's, like I said, mesenchymal stem cells. They come from blood and bone marrow. There are embryonic and fetal stem cells that we harvest from, fetus and embryos, and their potential to help are very different. Obviously, the more primitive ones can actually turn into nerves and neurons, etc. We really have an obligation to the patients to actually prove that they work or don't work. Unfortunately, many people have opened up stem cell factories and charge patients for these innovations. And there's very little documentation from investigators that are not sort of involved in creating them in a financial way. So we really need the FDA and NIH to approve studies to look at actual efficacy in a very blinded fashion and show that they either work, and in which case Medicare would cover it or that they don't work. And, unfortunately, all of this is, being financially driven right now. We do have some really talented investigators here at the University of Miami who are looking at mesenchymal stem cells for cardiac failure. And I think Ileana has featured some of these researchers before. But we have a long ways to go, particularly in neurosurgery, to show that there is efficacy for like nerve injury or spinal cord injury or stroke.
Yeah.
So Dr.
Go ahead.
Yeah, I think you've exhausted some of the point, unless you think that there's any new questions in the Q&A that you want to tackle.
Well, let's do one last one. So it's to Dr. Morcos, and it says, what field of clinical neurosurgery would you anticipate to be most influenced by
artificial intelligence?
AI, yeah.
Go for it.
Yeah, no, actually, I was in the middle of typing my response, but I was going to tell the person, I think functional neurosurgery, I mean, clearly. And we are actually recruiting one of our brilliant residents next year who I think will be a superstar in changing the field and brain-machine interface and trying to revive paralyzed limbs and so forth. I think this is where it's probably the most exciting, but of course it'll apply to everything like neuro-oncology and genetic signatures and even reading neuropathology. And will we still need neuropathologists or neuroradiologists in the future if we can certainly have machine learning on repetitive patterns that we see? Very, very interesting questions. Thank you.
Yeah, thank you.
Well, I think that this was a fascinating conversation. I think that your colleagues worldwide have appreciated it. And we cannot thank all of our expert panelists tonight for the generosity of their time. Chief Levy, our anchorman in the Q&A, Dr. Morcos, Dr. Peterson, you were very generous with your time. We really appreciate it. And thank all of you in the audience tonight for taking part. And we just want you to know that we are ready to take care of your patients at our UHealth facilities. Please visit uhealth.org to learn more about our topics covered tonight, or uhealthinternational.com to refer your patients for virtual in-person appointments with our experts, your choice. And please complete the survey at the end of this talk so that we can hear from you, get your feedback, and see if you want to hear from our experts on other topics. In the meantime, good night, everyone. Be safe. Stay well.
Thanks, guys.
Thank you.